Sir, please start.
Okay. Good evening, friends. I am Dr. Arun Bal, President of Diabetic Foot Society of India. Today, we have a webinar series session on
Sir,
plastic surgery procedures in diabetic foot
excuse me, sir.
management. Hello.
Sir, please इस अपना कैमरा थोड़ा पीछे कर लीजिए, थोड़ा दूर कर दीजिए कैमरा.
Okay.
Now is okay. Now start.
And today's our speaker is a very well-known esteemed person. His name is Dr. Raja Sabapathy. He is MS, MCH, DNB, FRCS from Glasgow, Edinburgh, and he has a honorary delete in science. He is the chairman Department of Plastic Reconstruction and Microsurgery in Ganga Hospital, Coimbatore. He is also president of Asia Pacific Federation of Societies of Surgery for Hand. He is a secretary general for the International Federation of Societies for Hand Surgery, Plastic Surgery for Royal College of Surgeons, and he is a visiting professor to many American universities in Singapore and Bangan. His academic awards are 104 and he has given 24 oration. So I request Dr. Raja Sabapathy to go ahead and give his presentation.
Yeah. So thank you so much, sir, for the introduction.
Share
And
the
um, uh, are you able to see the screen, sir?
No.
Yeah, share the share screen. Can you share? One second. Yeah, share screen.
Yeah.
Is it okay, sir, now, sir?
Yeah, fine. No problem.
Yes, sir.
Yeah.
So I thank the organizers and Dr. Arun Bal, who is the president of the DFSI, and he has been spearheading the academic activities of the organization. So for this opportunity, and for this Sunday evening, my duty is to speak on what a plastic surgeon does and what's their role in the management of diabetic foot. So first I'll start off with some points which will form as the basis of our talk and our work. It's the goal of all of us that when we meet a diabetic foot person like this, achieving wound healing and maintaining the healed status is very important. I think that's the most important thing. So the point number 2 is we are working in a system where we find that most of our diabetic foot ulcers occur in India in neuropathic foot. Surprisingly, we also found that most of our patients who come with diabetic ulcers, we feel a good palpable dorsal experience will be present in them. So we do have vascular foot, but still ulcers happen. And quite often people ask us, the common normal plastic surgical procedures, are they possible in a diabetic foot? So most often, regular reconstructive surgery options are available for them. Though we have to understand that there are certain inherent limitations imposed by the diabetic status. So they may have a certain kidney disease, or heart disease. So they are all compromised people. So we do have to operate with those limitations, but then the surgical techniques are possible. The third thing is that reconstructive surgery that we do is to help the wounds heal. And it is quite possible because the increased awareness of the anatomy of the blood supply of the foot has increased. So we are able to base our techniques in a better way. So following the landmark paper of Dr. Chris Settinger in 2006, the blood supply of the foot and the territories that each of those blood vessels, major blood supply, they're all divided as angiosomes. There are 6 angiosomes in the foot. And when you base your flaps, if you could base those flaps accordingly, the chances of success are higher. So that's the third point. And the fourth is, whatever you want to do, I think the most important is that you need to debride well. And a good flap or a good reconstructive technique cannot compensate a bad debridement. And as a plastic surgeon, because we are confident that we should be able to cover the wound, we are able to debride with a little more of courage. So that's what I usually tell our residents, that confidence in reconstruction gives us a lot of courage during debridement. And when you debride, with the point that we have in our mind is not what you remove. I think it is what you leave behind that is important. So we have to think that at the end of debridement, all that is left behind has got a good blood supply. I think that's very important. We cannot leave a bit left behind. We cannot leave behind hypovascular tissue. I think that's very important. If we have a good tissues with good blood supply, the antibiotic that we give perfuses those tissues, and over which we could do on our reconstructive procedures. That's what I say. Suppose you face there's a repeatedly debrided wound, so you extend the incision and then you really debride it very well. And because we are debrided well, for this patient we have put only a skin graft. I think it has done well. And that's because we have made a bed that is adequate and well prepared to take up a skin graft. So here again another patient we have, and then we have been already been grafted, come back. So what we have done is we are extensively debrided. So when the bed becomes better, then after that you put in a skin graft, it really takes up. So what is the common problem? I think many a time patients come to us and they say that they had a small great toe amputation, was a great toe ulcer was there. They amputated the great toe ulcer, or they amputated the great toe. Then what they find is that the abscess comes in the midfoot. Then we do something, drain it, and then they comes to the ankle, and then finally, God forbid, they may even end up in a below-knee amputation. So what really happens is, if you have this is a visible ulcer, and because they don't have much of sensation, so sometimes they may not have the pain that's there. They got a lot of pus that is there here. So here you need to open up and then see that. So when you open up, you find the tendon is bathed in pus. So here you do something, and then you cut away this infected tendon. If you cut, what happens? This tendon migrates and comes over here. So what we do is that we should do is that we need to reach an area where there is no infection, where there is a possible the pus could track. So there we reached up, and then we see the FHL tendon, and there we divide the tendon, and you must pull the tendon this way. I think you have to pull it out in this way. So in this way, what happens is that the infected load, I think it does not track down. So if it tracks down, what happens in this area provides a great amount of anaerobic environment for the bacteria to do. So then this does not heal. Suppose if you take off the tendon this way and then you close the wound, then it's possible that we'll be able to salvage this and prevent up further complications. This is the patient whom we did yesterday. I think yesterday we came and then they said multiple times, debrided, referred to us. But then it's quite obvious it has been inadequately debrided. And you find that the tendons, both the extensor tendons and the flexor tendons are exposed. And it's quite possible that they could have the tracking down of the pus in that way. And we also found some boggy swelling beneath the posterior to the medial malleolus. And if you really track it down, we found that there is a lot of pus even in the leg, the level of it. So that means, a good debridement is the first step of plastic surgery reconstruction. So you open up that those gangrenous toes were removed, and then we opened up here, and this area becomes like this. And you will find that the amount of tendon slough that was excised was this much. So once we do this, then it is possible to go forward. So I'm stressing this again because unless and until you debride well, that means, you cannot do well. So now what with the flaps for the foot that we take, as a plastic surgeon, we look at these flaps like this. The random pattern skin flaps means, they do not have a named vessel in the base. So suppose you have got a named vessel in the base, it is called axial skin flaps, and they serve better because they can hold on, the better territory could be formed. And the next part is that a muzzle flaps. Suppose you want to fill cavities. A skin flap cannot mold, whereas a muzzle flap can mold. So that's what is called as muzzle flaps that we have. And the prerequisite for doing any reconstructive surgery is that you need to have blood supply. I think without blood supply, we can't do. Plastic surgeon is totally helpless. So suppose you find that there is no blood supply, no pulses, That means you have to seek the help of a vascular surgeon to first of all to revascularize the foot. Without a good blood supply, a plastic surgery doesn't exist. I think it's always a battle between the ulcer and the blood supply. I think that's what is there. And now our safety of these operations is increased, and then we are able to do bigger and better procedures because of advances in anesthesia, the advent of the ultrasound in giving blocks for the anesthesiology. So we don't no longer give spinal. I think most of the times now you're able to do the femoral nerve blocks, and then the popliteal blocks, and then blocks. So only that limb is anesthetized. So that makes it surgery much more safer for these diabetic patients. Now we find, what do we do with the medial plantar artery? That group of things, what we do? So here you find an ulcer. I got it. And it has got it. When you debride it, it will form a cavity. And for this cavity, what you require is that now you need to have some filling space. Here you have the abductor hallucis brevis muscle. The blood supply of it comes in the base. So you got this much of the muscle you can take. You can fold it backwards and fill up the area and then hold it on. And so it heals and then gives fill. The same thing you can do with another muscle. I think the flexor digitorum brevis muscle, which is found beneath your plantar aponeurosis. You cut the plantar aponeurosis, open it, you get the flexor digitorum brevis muscle. You cut at the tendons and then fold them back. I think here again the blood supply comes over this area, so you could fold them back. So that means you can put it in the calcaneal cavity that is found over here. And when you say, you'll find that these areas, the red thing is that what it says is that the tremendous amount of pressure and then that is there. So we need to correct it. Unless you to correct it, it will recur. Next another flap which you found in the same group, medial plantar artery, is the medial artery instep flap. If you take the foot, this area is normally not in contact with the area. It's not non-weight bearing. So these are all weight bearing areas. So here you require a good skin. Whereas now here a skin graft would do. I think that's the idea with which we use. So what we do is that we got and then we Doppler and find the vessel over here. And we could isolate the vessel, so we could take it on only to their blood supply. And when you dissect it to a level like this, then what you could do is you could just turn it over 180 degrees. You can turn it over. So you can turn it over to 180 degrees and then put it on and put the graft on the other side. So in this way, we are having a glabrous skin in the area of the weight-bearing surface, and we are transferring the skin grafting area in the instep, which probably will not be having put into so much of pressure. So this is the pattern. Most of the flaps which you use based on the medial plantar artery and the lateral plantar artery. So here, this is the area which is supplied over. You could use a small transpositional flap, or you could use the whole thing and then transfer. I think that's what we have done here. So you choose the rotation flap. So when you use a major rotation flap, the incision is bigger, but then you don't leave behind a raw area. You don't leave behind a secondary defect. So I think that's what makes sense. So all of it is shifted back, and it's a random pattern flap, but then it's a big flap. It has got a big base. So it's quite possible that they live. Whereas you could use small flaps too. For example, a flap like this, VY advancement is made, and that's the flap that looks about a couple of weeks after that, and then a year after the flap that has been done. I think that's the way the same flap looks up. So another flap which is common, abductor digiti minimi flap. This is a small muscle. You don't get a big area. But here you find there's only a small part of the bone that is exposed. So for the small bone, we get a small flap. So we take the abductor digiti minimi muscle has been taken over and has been grafted. I think that's it. Now we come up to the calcaneal angiosome. So here is the small area. Here you again put a random flap. If you put a big incision, make it as a bigger incision you take, and then what will happen is now you are cheating the defect over a wide area, so that now you don't get any residual defect in the donor area. So next we come up to the peroneal angiosome. So I'm giving you a lot of examples, and then we go behind. Then I talk about the principles and how we choose, why we choose that, and their limitations, and we put that in the right perspective. So lateral calcaneal artery flap is a very, very good flap. It's a workhorse flap. Quite often you find in diabetics, the tendon Achilles ruptures, and some surgery is done, and the the tendo-Achilles area gets exposed. I think it's a disastrous situation. So it's one of the useful flaps that we have is a lateral calcaneal artery flap. So it's a very versatile flap. It's a very robust flap. We use it. But here, as I told you, so as I say, if you really notice, we use the transposition flap. So that means every transposition flap will have a donor deficit. I think the donor area has to be compensated by a skin graft. If you have a rotation flap, the flaps are bigger, but then no, there is no donor deficit, and then that's the way we use. And now that sort of perforated flaps have come because of the knowledge of increased knowledge in anatomy. We are able to find out which are the vessels which will supply and just base it on them and then rotate. I think the arc of rotation becomes higher. So for the same defect, we could do that. But then you'll find these cases, the scarring is a little bit more. So unless you are really pretty proficient and confident, you should be using these flaps. So the same thing, so where you are put back, I think that's a longer term result how it makes. But then in the selected cases, indicated cases, they all do very well. Now we come to the dorsum. Most of the time I find the ulcers that come on the dorsum are basically infective, secondary to an ingrowing toenail, an abscess over there, or some new chapel, they buy a shoe bite, and then they start. Most of them are infective. And very often you should be able to cover them with a skin graft after good debridement. But there are certain muscles which are helpless to the extent that digitorum brevis muscle. This we could sacrifice it because the long extends the tendency there. And if you take all the muscles, then you find a clumped up in this way. So this is a good muscle, So the blood supply comes from here. So you cut the tendons and then fold them back. And any defect over the ankle region, that's quite possible. And then you cover it with a graft, and then it stays put. I think it continues to heal. But then as I told you, I showed you some fancy flaps of basing it only on the vessels. So here you find the dorsal aspiratus goes there and dips in, and the plantar side, you get this. But then you have a defect here, and quite often many of them will be happy to have this toe knocked out, but then there will be certain people who really would say, I need to have the toe. And for such of those people, so what we do is to use it on the flap, fold it over back, and cover that area, and cover the rest of it with a skin graft. And later on, you could shave it back and then do it nicely so that that toe is good shaped. So now I showed you a lot of flaps. Now we need to put them all in a correct perspective, because it mustn't become a triumph of technology over reason. I think we should ask ourselves a question: are the flaps that a plastic surgeon does, are they a lasting solution? The answer is yes, if the defect is on a not weight-bearing area. If the defect is in a plantar weight-bearing area, you do a flap, I can't really say it might be, it could be, but definitely cannot say that it will be a lasting solution. For example, I'll show you some pictures. 2015, we had this. I showed you in that patient what I showed you. So it's healed very nicely. And if I stop here and don't show this picture, then you say, oh, fantastic. But then 2 years from the time we did this, I think he comes back with an ulcer over here. Okay. So I'll give you another example. 2012, this patient we had, and 2012 we did some procedures. We had this. And 2013, we reviewed him. He had like this. And 2017, I think he comes back with an ulcer. So the gap may be variable. I think it may be 1 year, it may be 5 years, it may be 10 years. But then, still again, I would say that this is not a lasting solution. But then, what else is the lasting solution? What should we do to make these things? The same patient, what we have done is that now we have corrected the biomechanics. We need to think, why did the ulcer come in the first place? Okay, and answer that question and provide a solution to the problem, why it can. I think most of the times is because of the altered biomechanics. And after you heal the ulcer, I think we need to address that also. I think that's the one you'll get. So what do you get when you do plastic surgery? You get a glabrous skin because you're covering the flaps that way. You get adequately padded, stable scar because you get a good scar. So you get that. And it buys the surgeon and the patient some time. I think that's very important. I think you heal the ulcer, they get better, so that now you can do the definitive procedure again. So what we don't get is that just because we don't we do a major plastic surgery they're not major actually, they are appropriate plastic surgery. So they don't, when your foot doesn't go away from the peripheral neuropathy the patient was suffering. It still remains the same. The biomechanical defect which caused it, that remains. So we don't get a permanently healed ulcer. So you need to do something to get the ulcer healed. And that's where a surgeon who is interested in the diabetic foot comes in. So the role of the local flaps is that, to summarize, it helps to heal the wound sooner. But then if it's just been putting on some ointments or some medicine, drugs, dressing, whack, all that, what I mean, they all take a much longer period. That's one. And secondly, you can then pump in them with antibiotics and all that, but then they could be resistant to the antibiotics. But as I'm very fond to say, so even till now, no bacteria has been found to be, has developed a resistance to scalpel. Surgeon's scalpel is still, I think, is more good. I think no bacteria has ever found a resistance to the scalpel. So it brings in more tissues that are more resistant to the gate. That's simple. And they need to be assisted by going a step further and offloading the pressure to help them provide a lasting solution. The offloading can be external. I think you can put some devices to do that, but ideally surgical to ensure better compliance in our people. So the next question, what is the plastic surgery? Where is a lot of the latest advances? Is microsurgery possible in diabetic foot? So what exactly is microsurgery do? Microsurgery, what it does is it allows us to transfer blobs of tissue from one place to another based on their blood supply. We take the tissue along with their artery and a vein and then go to the place of the defect and plug it onto a vessel over there so that it starts surviving in the place. So for that, it requires microsurgical skills, but more important than that, you need an artery and a vein in the place where it's quite possible. Sometimes, they may be the only option to prevent the proximal empty. Suppose you get like this, the bone is exposed and all that, so you got only these two, but still, this part of this column is quite okay. He could, if you are able to cover this and get a cover here, he could keep on going with this foot. Otherwise, he needs to have a proximal amputation. So here, what we have done is we have done a gracilis artery flap, and that's the place where we associate the dorsalis pedis and antitibial junction. That's the place we have caught it, and the vena comitatus, and that's the gracilis muscle with the vessels. We have attached that, and then over that, we have put in there. I am very convinced that in these type of patients, it's cost effective. I think it's the most appropriate. I think the reconstructed ladder, I think they come first. They come in the rungs of the ladder, they come first. And the time for healing, is much, much lesser. Once you debride well, and then you put in a flap, and it heals, God willing, it heals, and then it remains healed because it brings in new blood supply. It brings in new blood supply to the base, and provided, I think this could be the long-lasting solution for this. Another example where we have ulcer in the heel, and really a debridement has left a sort of a big defect, as a punched out defect in this place. Here you can't do any local flaps. And this cavity is much bigger for any of the local muscles. Then here what we do is just continue the exposure to the posterior artery. And sometimes these vessels in diabetics may be the single artery. So then what we do is to do an end-to-side anastomosis so that we continue to keep the blood supply distally, and then that's what we get. That is a picture which is taken of years after the original one. You see it has done well. And provided the individual takes care of the feet much well, I think they can go on and on and on they go. So another example, say you find a patient who has come, there is a lot of cellulitis, ascending cellulitis, he comes, you can see that. You debride and then leave them for a few days. Then after that, you find some wrinkles coming up, and then that means you're under control. But how do you bridge the gap? I think if you bridge the gap means if you have to bridge the gap because the bone you can't put in a graft. So otherwise, now you need to take all these back down. Then that's the arch of the foot collapses, that will cause problems. So what we do, again, we do a small muscle flap. Gracilis has been a workhorse for in these type of patients because There's negligible donor defect. I think you put in at this flap and you find, they're gone. There's a small gap which has been left to see the status of the flaps, and it goes on and on, and they do very well. So we have a spectrum. I'm doing a skin graft to microsurgery. So how do we choose as to what we do? We decide as to what we do by seeing the bed after we debride. If after debridement we find that the bed needs a flap, that means it has to get a flap. And it also, the other thing which will tell us as to what we could do is it depends on the presence of palpable pulses. And we have to look whether this patient can go in for about 4 to 5 hours of surgery, or he has to do only quick surgery because of his other comorbid factors. But now, these comorbid factors are really not very important, because with the improvement in anesthesia techniques, we find, particularly regional blocks, we are able to extend our level of care to these patients. So the whole spectrum can be from putting a skin graft to these people. I think that's again an example of skin graft. So here again, it looks bad, but then if you put in a skin graft and properly take care, it can be a lasting solution. It's not the size of the defect that counts. It's the bed that remains after you do that counts. I think you do it. So in these situations like this, where you have a long extensors open, what we many times we do is just take away the tendons and then put in a skin graft. You might wonder whether the toes will drop. They don't drop because the skin graft that is there inherently is tight. It just holds up. So you couldn't avoid a flap. I think that's exactly what we have done. And then it remains sealed. But you see, when you see the foot, you will find a lot of impressions like this. When he has come for a follow-up, we are taking this picture. That means he is on a compression dressing. I think he is having a compression stocking. So they don't allow edema to happen. They wash their feet nicely. And I think you need to educate them. I think that's a common part of reconstructive surgery. So once you take care of them, the feet take care of you for a longer time. So I showed you some skin grafts. From skin grafts to microsurgical free flaps you can do. So here you find a big, but then the artery was available to them, so that now we have done a graceless free flap. And there. Can we not do these major surgeries in a patient who has got no pulses? I think that's the question. So if you find a patient like this, and here it is referred at this stage, and we found that there's no palpable pulse, the blood supply was inadequate. So we are very clear that whatever we may do, even if you're the best of the reconstruction, you can't do anything, because you can't fight against a foot which has got no blood supply. So you need to seek the help of a vascular surgeon. I think they try to either do angioplasty, endovascular procedures, or open procedure, whichever is appropriate for the situation. And here they did a pulpit antitrivial bypass of the vein graft. They did. And after that, now we followed with the skin graft. Then usually when they do, it gives us a window of opportunity. Not that these vessels which they open up by bypass stay for permanently. Sometimes after a few months it might go, but it doesn't really matter, because it helps us to tide over the crisis. It produces a vascular foot. And with that, we do the reconstructive surgery. It makes the wound heal. And after that, if you are able to maintain them with good foot care, they are able to do well. So that's it. So the other thing where a plastic surgery procedures we do is that tendon transfers to altered biomechanics. You find first metatarsal head ulcer, you find. But if it is a second metatarsal, you can take off the metatarsal, but then you can't take the first metatarsal. So here you do a tendon transfer for them. And you have a claw toes and mallet toes. These are all very common procedures that are common situations that you will find in a diabetic. And if you have, you need to differentiate, because if you find the hyperextension of the MTP joint, that's a claw toe. Whereas if you find a flexion only at the DAP joint, then it's a mallet toe, and then the technique and the treatment differs for them. So suppose you have a claw toe, I think you need a different procedure. I think you need to extend the flexor tendon transfers. You need small tendon. It's not a big surgery. You need to do that. And once you do that, what happens is that the normalization of the pulp to floor contact. I'll go back and show you. If you have a claw toe, what happens is the tip touches the foot. And in this situation, the pressure on this small area, which is weight bearing, is much higher. And particularly insensate food, it leads to ulcers. It's sort of a pressure sore, that's it. But now, after we do this, after you correct the claw toe, you'll find that the toe stands nicely. I think that's what is the job of us. I think we do it up nicely and they do it. Sometimes, no, this also can happen in tendo Achilles. I think some weakening or tightness. I think it can be either tight or it can be weak. If the tendo Achilles is insufficient, what happens? The dorsiflexors act, so they all land on the heel. I think they keep landing on the heel, and then that's the reason for ulcer. So it is once the reconstruction surgery has been done, and it must have remained healed for some time, but then it comes back, and you will find that the amount of pressure that is there is so high. So the rest of the part doesn't touch back. So here what we do, I think we do a plastic surgical procedure to correct the foot, I think correct the ulcer, heal the ulcer. And then we are trying to beef up the pressure of the tendo Achilles. I think use the FHL. We do a tendon transfer procedures to offload it. I think we pick it up so that the heel is not the one always striking the ground. So the forefoot also needs to strike the ground. So to put it in the right perspective, plastic surgical procedures are extremely useful in the management of diabetic foot, I think. And if you really ask me, what is the most important thing that you do is that debridement. I think that's the key to success. You either make it or miss it in that stage. And no matter what, I think no material, whatever you use, whether you do plastic surgery or use negative pressure therapy, or you do the best of the antibiotics or ointments that you use, local applications that you use, unless and until you remove all the dead stuff, I think you can't win. So debridement is the key to success. And most of the times we are able to do that because we don't do that for that day. We don't plan for that day. I think we plan from start to finish. So you are able to look the whole length of this thing. You are able to look at the end result and the pathway. That's what I say. You have to visualize the end result and the pathway. And for those people who ask us, is diabetic foot ulcers, or for those people they are already compromised, I think should we have to do a plastic surgery possible? I think we have to say that most of the diabetic foot ulcers in India occur in the neuropathic foot and blood supply is sufficient. And if blood supply is not sufficient, we have got very good vascular surgery colleagues, who can help us to increase the blood supply in the foot at least for some time. I think that's possible. And then make the reconstructive options available to them. So I think I will leave off by putting a point that plastic surgeons have a great role to play in the management of diabetic foot. But it's just not enough to make ulcers heal. But then we also need to know how to prevent its recurrence. For that, one needs to think as to why the ulcers healed in the first place. So most important is that you must treat the cause. So recently we had a workshop of diabetic foot on 7th of February. And then we put up all the surgeries that I showed you. Most of the surgeries that I showed you, we demonstrated. And it's still available till 28th. Still you can join the meeting. Even though the conference is over, I think still you could join the meeting. So I once again thank Dr. Arun Bal, who is our president of the DFSI, for giving me this opportunity, and the HCFI for this opportunity. Okay, thank you so much.
I think there are some.
Yes, I think somebody is HCFI. I think he needs to wake up.
I think HCFI there is.
HCFI gentleman is laughing.
I'll just put forward the questions which we have received. One question from Dr. Nishit Patel. Which block for foot surgery?
Yeah. The question is, what is the blocks that you use for foot surgery? And we like to do these surgeries under tourniquet. And to enable us to we use the tourniquet, what we do is a combined common femoral and a popliteal block they give. and it allows us to put the tourniquet and do the whole surgery. Sometimes for debridement, they just give a popliteal nerve block. Popliteal block is one is given, and the tourniquet is put on the upper part of the leg. So that is also quite possible to do that. Popliteal block for debridement. For reconstructive surgery, a common femoral nerve block combined with a popliteal nerve block. It's a good question.
One more question from me, Dr. Raja.
Yeah. Yes, sir.
What do you find is the advantage of tourniquet?
Yeah, tourniquet, sir. Sorry?
What is the advantage of tourniquet?
Yeah, the advantage of tourniquet, I think it helps us during debridement in the sense we really like to leave behind every tissue that is vascular. So sometimes when you incise the skin, or which is good, the blood that comes out from the other side, it may cover it up, and then you find that the whole of it is covered with blood. Sometimes we may think that part is vascular, but in fact, no, it's the blood that has come from the other side. That is one. And secondly, there are certain muscle compartments, there are intramuscular planes where some say contaminants or infection may be lurking in. If we have a tourniquet, we can do it well. And what we do is that commonly we say tourniquet, without tourniquet, we assess the vascularity better. So what we do is we do this with the tourniquet, we let down the tourniquet and then see. Okay, then everything. I think ultimately the final assessment is made by letting down the tourniquet and seeing it, and then you find there are some areas which still need to be done. We again inflate the tourniquet and do it. So I think that is the advantage we find with tourniquet, and they are not been of any. They were not found any adverse effects because of using a tourniquet.
So, do you exsanguinate the leg or do you just elevate it?
If we just elevate it, so we don't exsanguinate it. Particularly in two conditions, you're not advised to exsanguinate. One is the infection. Again, if you put an exsanguinate by putting a plaster or something like a mark bandage, again that's bad. And we say once for infection, other for malignancy. I think don't put an mark bandage and push it down. We just elevate it, sir. We just elevate it for about 30 seconds. And it has been found that elevation of the limb for 30 seconds almost achieves 80 to 90% of what compression exsanguination could result. So elevation of the thing for 30 seconds should be fine. Okay. And elevation also not necessarily to the whole elevation. You just have to elevate it for about 2-3 feet. That's fine above the level of the heart. I think that should be fine.
There is another question by Dr. Vishay, which he is asked: what are the factors affecting skin grafts failure, especially in the plantar?
In the plantar hospital, I think what are the factors which affect the skin graft take and skin graft maintenance? Yeah. So basically, for graft take, I always say there must be close immobile contact with the bed, and the bed must be good. I think that's the point. You take a skin graft, I think that's good because you're taking it from a good area. So the graft is good and it is non-viable, and it must get blood supply to live. So the bed must be good. So you need to debride very well. I think there's 1, 2, 3, 4. If I ask me to list 10 points, I will say the first 5, good debridement, get a good bed. Okay. The next is close and immobile contact with the bed. I think that's a very nice thing. Close. That means it has to, if you have a contouring this day, you need to really patiently put it. I don't really staple up here and there. I do use quilting sutures. So if the contouring in the foot, you really do that very well. You make so that the grafts don't tent. You put a graft that you find there is a muscle there and there, that means it will tent. You have small amounts of areas which are tenting. That means in those areas the graft would not take. That's one. And then close contact means if you have hematoma, again you lose it. If you have infection in the bed, again you lose it because they don't they make the graft not close. They lift it up. And immobile contact. Do you use a tie over? Is the next question. I don't use a tie over, but I really take a lot of time to suture it nicely. Put in a gel net or something in your environment, keep it safe, and then put in soaked wet gauze pieces and then pack it up nicely. So in this way, we always mesh the graft. So if you just put it, and then what happens is as they're dry, they really hold it up nicely, and then it's quite good. So, and then the dressing changes we make depending upon the area that we are done, either about 3 days or 5 days, depending upon how confident you have been with the bed.
So, do you use dermatome or you do just with a
Yeah.
Humvee's knife?
We have both. I use the dermatome, and the younger surgeons use the dermatomes in our this thing. So I use the Humvee's knife. Normally the freehand knife only we use, but the dermatome is also there. I find dermatome has got a definite advantage if you have to cover a large area. That means when you use a Humvee's knife, there is a lot of serrations that happen in the edges. Whereas if you use a dermatome, it takes that edge becomes straight. So the next layer, that next graft you take, again, you can take it. So when in trauma, when you have a wide areas to cover, I find a definite dermatome has got a definite advantage. But in a diabetic foot, the extent of graft that may need may not be so much. So very often, quite often, you may get away with comfortably using a Humvee's knife.
Okay, then another question from Dr. Nishit Patel. Which book you suggest to make these procedures what you have explained?
Sorry, sir.
Which
I
book
couldn't.
do you
Which
that
book, sir? Sir, basically, this one of the must reading is Chris Settinger's article. I think most of them has not been a book. That article is very good. So the number of things that come up in journals than in books. I think that's what I find. As Nishit Patel has asked, that also shows that there is a lacuna. No, there is a space in the market for a good book which tells about how do we choose what to do. I think that shows there's a good mind. But most of the times, what we have followed is the articles that I come up in the journals, and by using those the articles written by Chris Settinger in PRS. I think they are the nice ones to base our work on.
Okay, there's a question by Dr. Bhavin Vitani. Is that what are the coverage issues in Charcot foot surgery?
Charcot foot surgery. I think Charcot foot, our President Dr. Arun Bal has passionately spoken in so many. So the problem in Charcot foot is a disorganized foot. So it's a disorganized foot where there's a tremendous amount of usually a midfoot collapse. So instead of the arch, the whole thing is collapsed and down. So it's a weight bearing area. I think instep, I was telling the instep doesn't bear weight. Whereas the many times in Charcot foot, the instep is what bearing weight. So here you find that you have got, if you have got ulcer, which is directly on the bone, sometimes you may have to nibble off the bone, which is causing the ulcer. But more important than that, you have to heal the wound. And after that, it has to be followed by an orthopedic procedure to creating the arch. You have to create a stable arch by correctly choosing the arthrodesis of these joints you have to put. So the ultimate answer to that question is you need to get back the arches if the bone stock is good. I think that will only be the lasting solution. But till the time, in the first step, to heal the ulcer, you follow the same principles. You debride well. If there be any particular projecting bone or something, nibble it up. You conservative dress, you get a still granulation, and then put in a graft or a flap that as you would choose. That would be the answer.
There is a question from the patient's foot.
Sir, so what is that? I couldn't hear you, sir.
How do you treat cons on the plantar aspect of foot of diabetic patients?
Yeah, cons, so I always find out whether it is due to why is it happened. First question I asked is, have you changed your footwear recently? So these are things that we have callosities, cons, we have. And if there's a good vascular foot, I exercise the cons, sir. And recently, what Dr. Madhu and all, they have my team. They're trying to use lasers, and they find that it is good. But then I would not like to comment on it till we go through a longer distance, long-term follow-up. Till that time, we are using the same straightforward general principles of how you treat a con with surgery. But most of the time, I do not use the con caps and all that. No, that part of it, and particularly those people who come to us have always already used, exhausted all those measures, and don't only come to us. So we are dealing with a subsect of population who really require good surgical treatment.
I think the cons in diabetic patients on the foot are because of a biomechanical imbalance.
Yes.
So that needs to be corrected either with a conservative treatment or surgical treatment. Then
Yes,
only they will go.
Yes.
So there is another question which asks that why do we scrape off hypergranulation tissue before putting a graft?
Yeah. So I could hear that. I think the voice was not. I could understand the first question. So why do we scrape off the granulation tissue?
We consider that when we think it is more vascular.
Yeah, okay, that's
why
good.
Do we scrape it off?
Yeah, that's a very good question, sir, because that is generally asked even for trauma, even for burns, everywhere, they could say. So the answer is, I think long back in Milisi, I think he was famously known for his nerve grafts. I think he has written a nice article on that. And he said, granulation tissue cannot appear unless there is some amount of mild hematoinfection. That cannot happen. So every granulation tissue, you will find there will be some subliminal amount of bacteria. So if you put that, though there is a lot of, you think there is a good blood supply, the graft would take, but then the secondary loss of graft later will be higher percentage if you put on a granulation tissue. Then on a bed where you scrape it off, there you get a clear bed and then put it. So I think that's the answer. So the percentage of secondary loss of graft is much higher, and if you directly put it over granulation tissue, then over when you scrape it to the base and then put it. You may say when you scrape it, there's a lot of bleeding. But then if you scrape it to the base, when there's no granulation tissue, the bleeding will be much lesser. I think that's the answer. If you just superficially scrape the granulation tissue, that's bad. If you just superficially scrape, then there's a lot of bleeding. But if you really scrape the whole thing, there's less bleeding.
Okay. So another thing what I wanted to ask you, do you put, after completing skin graft procedure, do you put, or have you tried putting a vac?
Yes, sir. Yes, we do. Yes, sir. We regularly, many of our colleagues in our department, they put a vac on this thing, sir. And if you really ask me whether you really require that, it, of course, if you put vac, it ensures that it is really stuck. I show you to ensure good graft take, you require close and immobile contact with the bed. So you could achieve that close immobile contact with the bed by properly padding with gauze pieces, moist wood, or all that. Or by putting a vac, it also ensures that it stays right. So if you continuously use vac for all cases, and the percentage of take, you will definitely might have a higher percentage of success where you put in a vac, definitely, because it uses all the mechanical pressures to do that. Whereas you need to think about the cost, and you need to think about the cost-benefit ratio. Accordingly, each of the places, you could, according to the patient, I think you can decide that.
Okay. So, Dr. Raja, that's all these questions.
Yes, sir.
I think it was a very useful presentation.
Yes.
And thanks on behalf of DFSI for contributing to our webinar series. You want to say anything else about education related to this?
I only will say that I should thank you, sir, for continuously doing a lot of educational initiatives. DFSI is very committed to spreading the education about how to caring for the diabetic foot in a very, very positive way. I think all of us are united in that effort, because we find, but by taking care of diabetic foot, I would say that we are contributing to the economy of the nation. I think that's what I would say in a very simple statement. If you want to put, I think we are taking care of the economy. It's one of the best ways of taking care of the economy of the nation in a brightest way. And we are now doing a lot of education to live operative sessions, as we showed you in the last slide. And we did a workshop. I think DFSA also does workshop, or Gango Hospital does workshops. We did it on 7th of February, and the whole of it is open. And for a very short, this thing of 2,500 rupees, still you could register for the 7 more days. It's available, and you could just see as if you are registered before the conference. So thank you so much, sir, for the opportunities. Okay. And I thank the organizers for doing this.
Thank you. IJCP, we can close. Can we close?
Yes, sir. Yes,
Anybody from IJCP?
Yes, sir.
Okay.
Yes.
Thank you.
Thank you so much.